So where is left side to normal. About the behavior committed to do.
Hello, doctors. Good evening and welcome to our session tonight. I'm glad to meet you online this evening. Today, we will have a discussion and we will practice scenarios in Station 2, Station 4, and Station 5. I am Dr. Nada Fawares, and I would like to have this session with you to make it an interactive session and to practice and share the hottest and latest appearing tricks and scenarios and have a discussion over them, okay? So as a start, I would like to ask you, and please you can respond in the chat box, okay? I would like to ask you, which station do you prefer to start with? Would you like to start with Station 4 or Station 2 or Station 5? Okay, we have here Station 4, Station 5, Station 5. I'll go with the majority, okay? We will practice them all, but which one to start with? This is the point. Okay, Station 5 has the majority right now. All right. Okay. Now regarding station, we will start then with Station 5, okay, first. And then we will go on with Station 4 and finally Station 2. Station 2 is also about a very important scenario, okay? And I have some things to say about that scenario. And now for Station 4, we will discuss a scenario where there is how to describe and how to explain to the patient about the NHS complaint system. You know, when the patient, whenever you get a scenario with a medical error or there is an issue of the patient is angry and he wants to complain and you give him the contact details of the PALS, okay? And then tonight, we'll discuss what's after giving the patient the contact details of the PALS, because the examiners are now asking about that. They ask, what do you know about the PALS? They ask, what do you know about the NHS complaint system? Even the surrogate may have that complaint as a concern. They may ask you, how can you help me, doctor, to complain? I want to complain. Please describe to me or help me or explain to me how I can do that. Okay, so it's very important that you have an information about that. All right. So let's start with Station 5 scenario, and we have Dr. Samia, sorry, I'll check the names of the doctors who already contacted me about Dr. Saadia and Dr. Samia. Are you there? If you are there, raise your hand, please. or else anyone can practice, okay? Dr. Samia, you said that you want station, is it okay to go with station 5?
Yes.
All right. So here is, just a second. Okay, here we go. All right, here is your scenario. I'll give you 3 minutes, okay, to prepare your answer and your differential diagnosis and your approach, and then we will start, okay? Before you start, Dr. Samia, please, doctors, is there any necessity to go on through the approach of station 5? Maybe there are some doctors who are beginners. Yeah, the voice is not clear. So would you like to start with explaining the approach for a few minutes and then go to the scenario? Hello?
Yes, doctor, if she is not available, can I start? Can I
No,
take the case?
I think she's there. Dr. Samia, can you hear me? Please respond.
Yes, I'm here.
Okay, I was asking you, doctors, do you need to go through the general approach of station 5 cases, or should we start with the scenario straight away? Okay, you can start, Dr. Samia. This is your scenario.
All right.
So, Dr. Samia, are you ready?
Yeah, I'm ready.
Okay, I'll just set the timer for you right now. And yeah, you can start.
Hello, this is Dr. Samia, one of the doctors here. Is this patient is male or female?
He is a male.
How old?
59.
Okay, thank you. Hello, this is Dr. Samia, one of the doctors here in the clinic. Is this Mr. X?
Yeah, it's me.
I'm just confirming your age. Are you 59 years of age?
Yes, that's correct.
Nice meeting you, Mr. X.
Nice to meet you too.
Mr. X, it seems that you're having some problems in your health, and I would like to ask your history and would do the examination after that. Is that fine with you?
Yeah, it's okay, doctor. Go on.
Can I know more about your complaints? What's going on?
Yeah, doctor, I have this, my knee. You see how it's swollen and it's very painful. And it's basically my right knee. And it has been like that for about a week now.
Did it start suddenly or gradually?
Well, it started, I don't remember exactly, but it started, I can say somehow suddenly, yeah. It was acute. Everything happened
Okay. All right.
rapidly, yeah.
Okay, so so since 1 week you're having pain in the knee. If we score the pain from 0 to 10, from 1 to 10, 1 will be the least and 10 is maximum. Can you score your pain, grade your pain?
I would probably say 7 or 8, but it's better now, doctor. I mean, I took some ibuprofen 2 days ago, and it's relieved now. It wasn't like that before when it started. It was more severe.
All right, I'm sorry for that. Let me see what's going on. This pain is only in the knee, or it's going anywhere else?
No, it's in my knee.
Okay. Is there any difficulty in moving, walking?
Yeah, somehow it's painful still, yeah.
How is it relieved?
I noticed that it was relieved by the ibuprofen.
Okay, and any thing with the rest or walking, is it aggravating?
Yeah, when I move it, it's painful when I move my knee.
All right. Do you have any past history of like high blood pressure
Yeah, oh yeah.
or any other problem like diabetes?
No, I am hypertensive.
Okay. May I know what medications are you taking for high blood pressure?
Yeah, I don't know its name, doctor, but I have the tablets with me. Would you like to take a look? It's
I would like to have a look at your
yeah,
medication list.
it's called thiazide. Hello? Hello? دكتورة سامية؟ Hello? Doctors, can you hear me?
Yes, Dr. Nada, we can hear you.
Okay, I think we Dr. Samia lost connection.
Can you hear me?
Yeah, now I can hear you. Okay, welcome
All
back.
right.
All right.
Okay. Can I know your medication list, please?
Yeah, doctor, I just started this thiazide treatment for hypertension about 10 days ago.
All right. Okay. Any over-the-counter medicines have you taken besides this?
No.
Before 10 days, you were not on any such medicines?
No.
Your control of blood pressure is adequate? What's your latest reading of blood pressure?
Before starting the thiazide, the doctor said that it was a little bit elevated. It was high. That's why we need to start the treatment. So I've been taking this thiazide only for 10 days now.
All right. I'm sorry to ask you one question, which I have to ask everyone, but it's a private question. I'm sorry for that. Are you using any illicit drugs?
No, I don't.
All right. Okay. May I know a little bit about your family history? Any family history of high blood pressure?
No.
Any family history of passing gravels or stone in the urine?
No.
Any family history of cancer?
No.
Any family history of note?
No.
Okay. What about your waterworks urine?
It's okay.
There's no frothy urine?
No.
Okay. I
Well,
would like to examine your...
there is only one thing, doctor, that I would mention. I've been there is that burning sensation in my waterworks when I pass urine. It's just burning. So that's the only thing regarding my waterworks, but no stones.
Oh, what did you say? I didn't hear it.
There is a burning sensation in the waterworks when I pass urine.
Oh, okay. Fine. There's no discoloration, red discoloration of the waterworks.
No.
Bowels are also fine.
Yeah.
Okay, I would like to examine you. While examining, I might ask you some questions. Is that fine with you?
Yeah, it's fine.
I will expose the patient's knee up to the mid-thigh. Both the knees should be exposed. Is it in, it seems that you are having problem in the right knee, is it?
Yes.
Any other joint involved in the body?
No.
Okay. I'm examining your knee now. I would like to check your pulse as in routine and
Yeah.
blood pressure.
No,
and
there is.
pressure.
Yeah, it's okay. No abnormality.
Okay, now I'll go to the local examination of the knee. First thing I'll check, I'll inspect. It seems that this right leg is swollen than the right knee is swollen than the left. And then I will check the temperature difference with the back of hand on the top
Okay.
of knee joint and in the surrounding area. Is there any difference?
Not really. It's there is a very minimal, but not very hot. Hello, Doctora Samia. My voice. Is there any problem with my voice?
There's no problem in your voice. I think there's a problem in Dr. Samia's connection.
It's clear. It's clear.
Okay, thank you. Yeah, no, I can't hear you, Doctora Samia.
Hello?
Yes.
Yeah. Okay.
Yeah. Okay.
There's no temperature difference. Is there any redness in the surrounding area suggestive of some cellulitis or inflammation?
You have 2 minutes left.
Is there any such thing?
No cellulitis. Just swelling and pain.
Okay. I'm just palpating gently the line of joint line horizontally. Is it tender?
Yeah.
And movement of joint, I would like to ask patient a passive movement. Is it possible?
It's restricted. It's painful.
Okay. May I know your concern, Mr. X?
My concern, doctor, I want to know, what is this condition?
I highly appreciate your concern, Mr. X. It seems that by asking your history and doing a detailed examination, there is some kind of inflammation in your knee joint. The probable cause of this is related to the medication which you have started. I would like to keep you in the hospital and run battery of investigations and do an imaging of your knee and to see what is going on. I will also frame a multidisciplinary team involving a joint doctor and a physiotherapist as well, and will do the needful after doing complete evaluation by investigation. Is that fine with you?
Yeah, it's okay, but will it happen again? I mean, you said it's because of my treatment. Is it a possibility that it will happen again?
It can happen again. So I would like to ask your blood pressure doctor, who might be a physician. We will involve him as well, and probably the change of medication would be very important in this regard. Are you smoking?
Yeah, I do smoke.
How many cigarettes?
About 15.
Have you ever thought of quitting?
Not really.
I would. It's better you quit the cigarettes because cigarette, as everyone, not good for health. I will send you to the smoking clinic if it's
Okay.
okay
Your
with you.
time. Your time
Are
is
you
out.
drinking
Your time is out.
alcohol?
But I will let you
Okay.
continue. I will give you 1 extra minute. Okay.
Okay. Are you
Ask
drinking
what you-
alcohol?
Yes,
Are you
I do.
drinking alcohol?
Yes.
How many units? How many units?
Between 25 to 30 units a week.
I'm really sorry that you need to really quit alcohol. I would send you to the cessation groups, which might help you in avoiding, because this motivated.
Okay. All right. Dr. Samia lost connection again, I guess. Okay, so I hope you can get back soon, Dr. Samia. Your time is out anyway. So now the further questions will be about what's your diagnosis? What's your diagnosis?
Can you hear
And
me?
yeah.
Hello.
Yeah.
Okay.
So what's your diagnosis?
My diagnosis is it's an acute onset of a knee joint secondary to the crystal deposition, most likely gout, most likely gout, secondary to thiazide hyperuricemia, secondary
Yeah. Okay.
to thiazide diuretics.
All right. So how will you investigate?
I would first CRP and inflammatory markers and ECG, X-ray of the joint, and we'll do an aspiration of the joint. That is very important in order to differentiate between a septic arthritis and this. We will have to see these crystals, and which will be show these uric acid crystals. We can like see negative by refrigeration.
Okay, and how will you treat?
I will first change the medication with the help of a physician from thiazides to other medications, which will be good for his high blood pressure. Since there's no family history of any hyperuricemia or any other, I would like to ask his diet intake also. I would restrict the purine diet rich in purines. And I will give him anti-inflammatory presently, like non-steroidal anti-inflammatory, or we can even give the colchicine as of now if there is any contraindication for non-steroidal. Then acute phase settles, we will give him medications like we can give allopurinol inhibitors.
Okay.
Xanthine oxidase inhibitors like allopurinol or febuxostat.
Okay. Did you ask about his diet?
No, I was really about to ask, but I was short of time. Actually,
Yeah. So if you asked me, if you asked me, this gentleman, he is on a excessive red meat dietary intake. So you have to give him an advice about cutting down that, and also refer him to the dietitian to give him more advice and more dietary control. Okay. So yeah, indeed, this is a case of right knee gouty arthritis. It came in the last exam, Diet 3 exam, and it was exactly this case. Okay, so let's take a look at the, just to recap, approach in joint swelling or pain. In the exam, if you got a scenario about joint pain or joint swelling, arthritis or arthralgia, okay, so it's important to ask about whether if this pain or the swelling is improving with movement or rest, as you asked me, Dr. Samia, and also to check if it's associated with any stiffness or hyperextendable joints. So usually when there is a joint problem, okay, even in the small joints of the hands, or any joint problem like shoulder pain or knee pain or so, okay, we usually we commonly ask about joint stiffness, morning stiffness, and so on, for how long, etc. Okay, but my advice for you is also to ask about if there is any hyperextendability or not, okay? Because you may get a case where there is joint pain, and that's the basic complaint of the patient. It could be a large joint, it could be small joints of the hand, okay? And the issue is not in stiffness, it is in hyperextendability, okay? And I got that case in my exam a few years ago, okay? My case was Ehlers-Danlos syndrome, and the young lady, she presented with shoulder pain, okay? Basically, they mentioned that she has joint pain, okay? And among these joints was the shoulder. So when I entered into the station, I found her sitting, and when I asked her about the site of the pain, she localized it and said it's affecting her shoulder. It was the right shoulder. And when I asked her about any other joints involved, there were no other joints involved. And what about joint stiffness? She said, no, I don't have any stiffness. And I asked her, do you have any extendability of your joints? She said, yes. So from there, I took it from there, and I asked her to show me how is that, and she started to show me about she was doing habitual shoulder dislocation. She was dislocating her shoulder and replacing it back, and that caused some pain to her, and she needed a physiotherapy, and I took the discussion and treatment of that from there. So my point here is that you may spot the condition. It could be, of course, Ehlers-Danlos, it could be Marfan, it could be any collagen disease, pseudoxanthoma elasticum, etc. So it will take you to a different differential or different group of diseases, just if you ask if she has any hyperextendability or not. Because you have diseases with joint stiffness, the rheumatology diseases like rheumatoid arthritis, like etc. Okay, and then you have, on the other hand, some conditions with hyperextendability, and both can cause joint pain. Okay, now if there is any stiffness, she says if there is a stiffness, you have to ask for how long. The duration is important, in the morning or in the night mainly. Any change in the color of her fingers when exposed to cold. Is it associated with Raynaud's phenomena, or is it just Raynaud's disease? Okay, skin tightness and thickness, just to exclude some rheumatological diseases. No, Dr. Sam, you didn't ask me about any red eyes, redness in my eyes, any mouth or genital ulcers. Okay.
Yeah, I didn't ask.
Yes, because that's important too. All right. Then any associated skin rash in the face or rash while exposed to the sunlight, any grady sensation, redness in the eyes, sore mouth, soreness in the private areas, okay, any difficulty swallowing. So by that, we are excluding any associated symptoms, which may be differential diagnosis with joint pain, okay, just to exclude the differentials one by one, which the rheumatological diseases are a part of. Okay, so any difficulty swallowing, difficulty breathing, any chest pain, tummy pain, bloody loose motion, frothy water. He said he doesn't have frothy water. You asked about that, just some dysuria, change in the color of the water, any lumps and bumps, lymph nodes, lymphadenopathy, okay, lymph nodes or tumors or whatever. History of blood clot formation, Paget cancer, antiphospholipid antibody syndrome, the familial diseases. You asked in the family history about any cancer, history of cancer, or any diseases in the family, etc. Okay, if she was a female, ask about any history of miscarriage, any back pain, history of trauma. Okay, and then ask about the medication list. So these are the things to go through in station 5 whenever you have a joint swelling or joint pain. Okay. It could be involving a large joint. It could be involving small joints, depending on the situation. Okay. So thank you very much. You did very well, I think. Okay, you spotted the diagnosis. You mentioned most of the important things. The dietary history was very important to spot. Also, the alcohol consumption, okay, was important because you run out of time when you mentioned the alcohol. Okay, so please keep that in mind. And the oral ulcers and things in those questions, and the redness of the eyes and back pain, were missed also. But overall, you spotted the diagnosis and your approach was very well. Your discussion was very well as too. Okay, so that was station 5. I'm still asking you, doctors, if you need me to go through a general approach for station 5 scenarios, I can do that. Okay, because some of you are preparing for PACES for the first time, so maybe you don't have a clear idea about the approach yet. And some of you are very advanced and you are very well prepared. So that's why I'm asking you. Or else we will now move on to station 4.
Hi there, Dr. Nada. I have one question.
Yeah.
It's Dr. Lalite. In station 5, like she did very well, and she knew that it is because of thiazide. Do we still need to ask some other questions to rule out some other things? Like we can ask any nail changes or patch of psoriasis somewhere. As you said, we can ask about waterwork changes and the red eyes. Do we need to ask other things as well, even if we know that this is because of thiazide or something else?
Yes, because you are assessing the possible causes of this joint swelling. We're not sure yet. It could be due to thiazide. That's one of the possibilities. But what if she had bloody diarrhea? Maybe it's reactive arthritis. Okay.
Yeah, that's true.
Yeah. Maybe it's reactive arthritis due to gonorrhea or something. He said he has dysuria. Okay. Maybe.
Yeah.
So there are other possibilities. So that's why we're asking in the history to rule out most of these possibilities. And then the approach of investigation will be directed towards our most highly suspected differentials. And that's actually the aim of station 5, to rule out any differential diagnosis. Okay?
Right. And doctor, she was having pain and redness and swelling kind of in the knee joint. So
Yeah.
on examination, do we need to examine, like, if she has a pain, do we need to make her move and everything? Or
no, I liked the way Dr. Samia did. She asked the patient to try to do a passive movement if that's possible. And I said, I can't, it's painful. Okay. So instead of just moving the patient actively, ask him if he has any pain. If it's painful, ask him if he can move his joint passively, slightly by his own, on his own. Okay. If not, then I mean, don't expose the patient to pain. Okay. So
doctor.
yeah. So but you can. Tenderness and temperature and hotness and those things, just take permission from the patient. And if there is no tenderness and he said that you can touch it, the most important thing is to take permission and don't expose the patient to discomfort or any pain. Okay. So the other causes, if he was at a younger age, that's why we're asking about familial bleeding disorders. Maybe there's hemarthrosis, maybe he has hemophilia. Okay.
Yeah.
So yeah, any history of trauma, medication list, diet, alcohol, excessive meat consumption, any reactive arthritis, any. So these are the differential diagnosis, and these are the things you need to ask about in the history. Okay. So this slide will help you to rule out many differentials. Okay.
All right. Thank you,
All
doctor.
right. Most welcome. So let's move on to station 4, if there are no further questions. Okay, here we have a question. Tell me how to prepare station 5 as I'm a beginner. My exam is in March. All right, I will go through a slide. I have a slide, okay, where there is a summation of the steps to approach, at least how to approach station 5, okay, in just 2 minutes. And then we will go on to station 4. Just a second, I'll share the slide with you, okay. So here is the station 5 integrated approach. I shared the screen with you, doctors, so I hope you can see it. Okay, so here is the approach. In the exam, you will get 2 cases of brief clinical assessment. Okay, each one of them is for 10 minutes. Okay, and so before you enter into the station, you will get an introductory referral letter where there is a hint about the patient's major complaint and what you need to do. Okay, so you will get that introductory referral letter before you enter into the station, and then you will go inside. You will find 2 examiners and the surrogate. Okay, or the patient. So you will be allowed to spend 8 minutes with the patient, and then after 6 minutes are over, the examiners will say that you have 2 minutes left, and then you have to start your discussion with the patient and ask about the concerns, and then the 8 minutes are over, you'll have 2 further minutes as a discussion with the examiners, and then you will go into the other case in the other room, and so on. Okay, so scenarios to expect in station 5 are basically you may get an inpatient. In the referral letter, you may get an outpatient referred to you, or the patient may be admitted already, so he is an inpatient. The difference between having an inpatient or an outpatient is that the inpatient may have a chart beside the bed. You may need to take a look at the vital signs. You may need to take a look at the drug list. Okay, and if it was an outpatient, then it's an outpatient. There is no drug list or drug chart or any vital signs chart. Okay, so scenarios to expect usually in station 5: skin, eye scenarios, locomotor, endocrine systems. Okay, sometimes you may get other stations of the exam from station 1 and 3. Okay, like a cardiology case or neurology case or an case in abdomen or something. Okay, so you may get from station 1 and 3 cases, and you may get skin, eye, locomotor, and endocrine system cases. Okay, other possibilities are medical problems encountered in everyday practice. You may get a patient with a chest pain. Okay, and you have to assess this chest pain and approach that chest pain and reach the diagnosis and deal with the patient's concern. You may get hypertension, jaundice, deterioration in renal function because, for example, of drugs or contrast imaging, or acute renal failure because of dehydration. Okay, so these are the possible case scenarios you may get in station 5. So this is a general approach. Okay, candidate information. 5 minutes. You need to identify the clinical problems and list your DD. These 5 minutes are before you enter into the exam room. So here you're still sitting in front of the examination door. You didn't enter yet. So you will get that small piece of referral information, okay, just to have a look at it and identify the clinical problem, and you can start to list your differential diagnosis before you enter inside. But as soon as you start to ask the patient, ask the surrogate, then your differential diagnosis will start to be more clear. Okay, when you enter into the examination room, you should start to take focused history. History and examinations should be integrated. So this is a very important part of station 5. Okay, don't start to take purely history and just forget about the time. Okay, because you have around 6 to 7 minutes to spend with the surrogate, and then you're not allowed. 6 to 7 minutes to take history and examine the surrogate, and then you have 1 or 2 minutes to ask them about their concerns, solve the concerns, explain the possible differential diagnosis and how to treat them and how to investigate them, and so on. So you have a lot to say, much to say before your time is over. Okay, so here is a thing, make it as an integrated history taking and examination at the same time. So you can start by asking the patient a few questions, okay, like analyze the main complaint at the beginning, and then start to exclude your differential diagnosis by asking the patient about the cardinal symptoms and associated symptoms of each differential to rule them out, and then tell the patient that you will still ask them a few questions as you are examining them, and go on and take focused or make it a focused examination. And if you remember anything while you are examining the patient, you can go back and take the history again, okay? It's okay. So you can both ask questions, take history, and examine the patient in the same time, okay? So that you don't miss out, you don't run out of time. Okay, so history and examination should be integrated. If the patient is an inpatient, check observation or drug charts if available. Then feedback to the patient in 1 minute. Here you need to explain the diagnosis or the differentials you have. Remember, avoid medical jargon. Relate them to the patient's symptoms to help him understanding. Like, for example, he says, doctor, what's my problem? And you say, for example, you have a reflux, or let's say we're talking about a chest pain and the patient seems to have gastroesophageal reflux disease. So explain that this discomfort or the burning pain you're suffering from, it's because of, so always refer it to the patient's symptoms to make it clearer so that he can understand you better, okay? And then explain your initial plans, what you're going to do for him, any further investigations you need to request, and how you're going to manage him. Ask about his concerns, confirm his understanding, answer his questions, and now you have 2 minutes with the examiner where you need to summarize your key history and examination findings, give your diagnosis or your differentials, give supporting evidence, outline the investigations and the management plan. That's basically 10 minutes, okay, and the station 5 is over. So that was the approach for the doctors who asked about it in the chat box, okay? So now let's go to station 4. So this scenario is basically about the NHS complaint system, okay? And there are some few things I want to say here, okay, as in the discussion. So I just we have Dr. Sadia. Are you there? Or Sadia, Dr. Sadia?
Yes, ma'am, I'm here.
All right. So here is your scenario, and I'll give you 5 minutes. All right. Prepare yourself, and then we will start.
Okay, right.
Okay. Do you need me to read the scenario, doctors, or is it okay? It's already shared on the screen. Hello, Dr. Sadia.
Yes, ma'am.
Okay, is your internet connection good? This is the first thing to check.
I think this is working good right now.
All right. So you can start.
Okay, right. Hello, good morning.
Good morning, doctor.
I'm Dr. Javed. I'm one of the doctor on duty today. You must be Mrs. Giuliani 45 years ago. 45 years,
Yeah,
sorry, 5 years old.
yeah, I'm 45. Yeah, it's
Okay,
correct.
right. Mrs. Giuliani, we are here to discuss about your problem. Is that fine with you?
Yeah, it's okay.
Okay, right. And do you want anyone else to join the meeting?
No, it's okay.
Okay, right. So tell me, how can I help you today?
Well, I'm here today because I'm supposed to have a 6-month follow-up visit after having my surgery.
Yeah. And how are you feeling?
Yeah, I feel much better.
Okay, right. So after the surgery, your symptoms have improved now?
Yeah, much
Oh,
better.
okay, right. And can you tell me, do you have any headache or any visual problems now?
No,
Okay, right. Okay. Okay, right. So, do you have any concern, Mrs. Kalyani?
yeah. Actually, I'm here today because you said that you want to see me after 6 months, and as I feel better, and so um, I want to ask about, you know, if you are aware about what happened, doctor. I went to my GP at the beginning, and I was following with him because I had that awful, I had that headache for 2 years, and I was visiting him frequently, repeatedly, and he didn't want to investigate me further. So then finally, when it was discovered that I had a tumor in my head, and the tumor was removed by surgery. Now, I would like to I would like to ask you, okay, what do you think about that? I mean, he clearly messed up, right? Um, what do you think? I mean, why didn't my GP send me for investigation 2 years ago? Why did it take all that time till 9 months ago, or about 9 to 6 months ago, to be discovered? Now I've been visiting him for so long, over 2 years, and he was just prescribing painkillers for me. So what do you think, doctor? I want to make a complaint, and I think that he clearly messed up.
I'm really sorry, Mrs. Kalyani, for what has happened, and I really appreciate your concern. But that's really good that you were diagnosed that you're having this growth and you have undergone the surgery, and that's really good that you are doing well. But I'm really not sure for what has happened, and I have to look into the matter, and we will look what has happened, because I wasn't there and I'm not aware that what the situation was at that time. Are you getting
Yeah,
me? Kalyani?
yeah, but doctor, I don't know. I mean, did he make a mistake, or what happened? Why did it take so long? Why did you make his surgery and you found that tumor? Why didn't he recognize that? Why did it take so long?
I'm really sorry, Ms. Kalyani, and I can imagine your worry, because it should not be like this and it should be investigated earlier. And regarding your concern of making complaint, it's absolutely right. But I'm really not sure what has happened. Are you getting me, Mrs. Kalyani?
Yeah.
Yeah. If you want, so I can refer you to the patient advice and liaison service to launch a complaint. And I'm really sorry for what has happened, but it's really good that you ended in the surgery and things have gone.
Okay. Okay. So if I want to complain, make a formal complaint, how is that done? Can you guide me?
Yeah, Ms. Kalyani, it's absolutely right, and I can refer you to the GP manager who can help you in raising complaint.
Okay.
Okay, are you getting me?
Yeah.
Yeah. Do you have any other concern, Ms. Kalyani?
No.
Okay, right. So can you tell me what you do?
I am an accountant.
Okay, right. And any problem in your job or activity daily living?
No.
Okay, right. And with whom you live?
I live with my husband and I have two teenage children.
Okay,
I live
right.
with my family.
Great.
Yeah.
Okay, right. So do you have any problem regarding taking care of your children's or in daily activities?
No.
Okay, right. And do you drive?
No, I don't.
Okay, right. And do you have any other concern, Mrs. Kalyani?
No. I just want
Okay,
to
right.
know how to make that complaint because doctor, my GP, he didn't send further investigation to investigate my headache till the point when I have my sister. Um, yeah, my sister. She has some practice with law. She's specialized. Uh, uh, she's legally trained. Okay, I took her with me, and with her support and assertiveness, she convinced my GP to carry out further investigations. I don't know why he didn't want to investigate me for the headache, which I was having for 2 months. And after that, the investigation showed the CT scan of my head was arranged soon after, and it showed a suspicious mass in my brain. And then an MRI of my head confirmed an early stage brain tumor. The doctor said that it was called some meningioma or something, and they needed to refer me to have an urgent appointment with a neurosurgeon in the neurologist. And quickly, fortunately, the biopsies and repeated MRI scan 2 months later, they proved that it was not a nasty kind of tumor, and it was fully removed. So that's why I don't get it. Why didn't my GP refer me earlier? What was he waiting for? I mean, what could have happened if it was turned out to be a nasty growth or a nasty cancer, for example? That's
I can
why.
imagine. Yeah, Miss Giuliani, you have suffered a lot because of this headache, and
We have
um,
2 minutes
things
left.
have things have got delayed, and it should be diagnosed earlier. But we just want to make things better for you and things easier for you. And regarding the issue of complaint, we'll be referring you to the GP manager so you can launch your complaint. And we'll be discussing this case in our mobility and mortality meeting to avoid such things happening in the near future also. And I will involve my consultant also to look into this matter.
Okay.
Okay. Do you have any other concerns, Ms. Giuliani?
No.
Okay, so you have to be in close follow-up, and you'll be taking care of your medications and take care of your symptoms. If heaven forbid you're having any problem like your vision problem, like any headache, so you have to come to the emerge to the hospital urgently, and just keep close your follow-up. So you'll be in close monitoring, and everything will be controlled, hopefully.
Okay.
Okay, any other concerns, Giuliani?
No.
Okay, right. Okay. Thank you, Ms. Giuliani.
Okay. Did you finish?
Yeah.
Okay. Please summarize your discussion.
So Ms. Giuliani, which was diagnosed 6 months, she had a follow-up 6 months after resection of the low-grade meningioma. And she was initially had a headache for the 2 years, and she was initially treated with lines of migraine. Although she had recurrent visits to the GP, but lately she had a CT scan which showed that she's having meningioma, and she was completely meningioma was rejected completely by neurosurgeons, and that's why she's here for the follow-up, and she was willing to launch a complaint against the GP.
Okay, so how would you respond to her concern about the GP?
So I have to say that I'm not sure what exactly happened, and I'm really sorry for what has
Okay,
happened. Okay, should I proceed or?
yes.
Yeah. So I have to say that it was definitely an error because she was
All right.
diagnosed late. So if she is willing to launch a complaint, so I can send her to the GP manager,
Mm-hmm.
GP practitioner manager. So she can launch a complaint.
Hello?
Yeah, hello.
Hello?
Yeah, yeah. Can you hear me? Hello, I can hear you.
No, I can't hear you clearly. I don't know if the...
My net is working, I
Okay.
think. Yeah,
All
I
right.
can hear you.
So,
Hello. Hello.
hello. I'm sorry for the interruption.
No problem.
I was disconnected for a few seconds. Okay, so here is the as you said, it seems like it was a delayed diagnosis. Okay, and this delayed diagnosis, however, you were not there, and it's unprofessional to blame your colleague, especially that you don't have the um, all the facts and the documents. So, and she's speaking about her GP. So here is what to do, okay?
Okay.
So the discussion here in this case, it's about she is blaming her GP for delaying the diagnosis, and she is blaming him that he messed up, and that's why she wants to complain. Okay, so the candidate should be able to assess the patient's recovery post resection. Remember, this was your task: assess Mrs. Giuliani's recovery. And you ask about if there are still any headache or something, and I said no. Okay, and ask specifically about any symptoms suggestive of a recurrence or incomplete resection of the tumor, like if the headaches are persistent, if she had any seizures, does she have any visual symptoms, weakness of the face or upper or lower limbs. Okay, some of you may ask me, this is history taking, and we are in station 4, but this is your task. This is how you're going to assess her. Okay, so these are specifically the symptoms suggestive of either recurrence or incomplete resection, and that's the task. It says assess Mrs. Giuliani's recovery after resection of her meningioma. So these few questions, you can ask them, okay? They would not be considered as history taking here.
Okay.
And then reassure her that the neurosurgical team resected the tumor in confidence, and it was removed completely. And the biopsy results and the MRI scan, which done 2 months after the operation, also suggested this. So reassure her that she's doing fine. Okay, reassure her that it's unlikely that she needs any further treatment at this step, like radiotherapy or anything like that. Okay, but that we are going to keep her under close surveillance and follow up, and she will need to have an annual MRI scan for the first 5 years. So she needs to know about these things. So this is the issue related to her medical problem. We have issues related to the medical problem here and issues related to the ethical aspect. The scenario here talks about her clinical problem, the headache, the meningioma, the post-surgical recovery. The other section of the station or of the scenario is about her concern, and her concern is specifically about ethical and legal aspects and how to take the matter further. If
Hello.
حبيبي والدتك حبيبي. ده. اقفل بقى الباب، خدها واقفل الباب. طيب شكرا.
So here, when she mentioned about the complaint, okay, so here is what to do. Because this is a scenario with a special approach. It's not like the other scenarios. It has some special situation, okay? So the discussion should include that the candidate should be able to assess the patient's recovery post resection, because again, it's your task of the intracranial tumor, looking out particularly for symptoms and signs of any recurrence. Then carefully listen to her concerns regarding the delay in the diagnosis and try to tease out the facts from the opinions. I was expecting you to ask me to tell you what happened, but you didn't. Just said that you wasn't there and you cannot make a decision about that. But however, you will refer me to the GP practice manager. That's fine. But I was asking you to guide me, to advise me. What do you think, doctor? Okay. So here, when a patient asks you like that, to tell them about the NHS complaint procedure and how they can do that, it's expected that you can give them some explanation about the process. Okay. It doesn't mean that you are telling her go and complain. That's her wish. She has the right to decide whether she wants to complain or not. It's her right, okay? But she asked you to explain about the NHS complaint procedure to her, okay? So ask her to tell you what happened, what her understanding about what happened from the start. So as she was explaining, she had headache and she was misdiagnosed, mismanaged. And then when she took her legally trained sister with her, finally the GP agreed to request a CT scan where a big tumor was found. Okay, so that's the issue here. So give the patient factual and objective advice about how she can take her complaint further if she wishes to, while demonstrating professionalism toward other medical colleagues. The professionalism here is that not to blame your colleague or the GP, okay, without any factual facts or any documents, because after all, that's not your job anyway. Okay, so just respond to the patient's questions and tell her the following. If she asks regarding the complaint procedure, how can I take the complaint further? Here, you can explain that if she chooses to seek legal advice, okay, then an expert opinion will be sought.
المهم إني أتوب إليه. يعني.
If she's asking regarding the complaint procedure, okay, so you can explain that if she chooses to seek legal advice, then an expert opinion will be sought, someone who's expert in this field, to detect and establish if her GP was failed in his duty of care or not. That's not your decision, okay, if she asks to, if she wants to complain. All right, and that takes us to the point where, you know, sometimes in the exam there are some tricky situations. You will get a scenario about a medical error in the exam, and apparently it is, in fact, it could be going with negligence, okay, rather than medical error, okay, because there is a difference between when there is a breach in the appropriate standard of care, and the doctor may be negligent and maybe not. So never mention to the patient that there is an issue of negligence in the exam if you are dealing with a scenario of possible negligence. Okay, why? Because negligence is something, it's a situation that needs to be assessed by someone expert, legally expert. It's not something that you can make a decision about just from reading a scenario. Okay, but medical error, yes, it's going to be obvious if there was a mistake happen, an error happened or not. But was that error actually a negligence or not? There are some conditions that need to be fulfilled in order to say that this is a negligence. So in the exam, if the surrogate, okay, asked you, is there a negligence or a medical error in the scenario, doctor? Even if you feel that there might be some negligence, you say this is a medical error. If the surrogate asked you, is this negligence, doctor? You say here it's difficult to decide whether if it's negligence or not just from this meeting, from the scenario, because this needs further actions to be taken and further investigation. Legal experts need to decide whether if it's negligence or not, because there are the 4 Ds of negligence that needs to be fulfilled in order to say this is negligence or not. Okay, but if there is a medical error, yeah, there was a medical error, but negligence or not, this is still early to decide. Okay, so expert opinion need to be taken, legal experts, and they need to investigate the issue further. The negligence issue needs a lengthy explanation, and that needs a separate lecture. So I'm not going to go through this tonight, okay? But just to hint about it as we are talking about this point specifically, okay? Even in the examiner, if he asks you a negligence scenario, is there negligence or not? Don't rush and jump straight to and say, yes, this is negligence, 100% sure. No, there was a mistake that happened. It is an error, yeah. Where is it negligence or not? There could be a possibility of negligence, but that needs further investigation. Okay, there are some conditions that needs to be fulfilled in order to say that this is actually negligence or not. So there is a possibility that it could be negligence, but it's difficult to say right now from this scenario, just from the scenario, that there was a negligence. Okay, and so that's my suggestion about how to respond. But you say there is definitely a medical error that happened. Okay, because for some examiners, they are irritated by the word when you say it's negligence straight away. Okay, they don't like that. But if you say medical error, it's accepted better, and you explain that why you didn't say negligence. Just explain to them why you didn't say that, because there are some legal points that need to be fulfilled to decide if there was negligence or not so far. But there could be a possibility, but it's difficult to decide right now. Okay, let's get back to our lecture. Explain tactfully that while you cannot become involved in the complaint personally, because she was asking for your opinion, and you, as you said, I wasn't there, I don't know what happened. So you cannot become involved in the complaint personally. So, but your consultant and the neurosurgeon who did the operation, they can certainly be contacted either by the patient, the patient, the surrogate, or by a legal representative with a request to send information. So we can provide information, clinical letters about the assessment which was done in the hospital after the meningioma was diagnosed, the diagnosis, if that was requested by those investigating the complaint. So you cannot be involved directly, but if they needed any information from our part, okay, because the patient was referred to us, we diagnosed her, we did the operation, referred her to the neurosurgeon, and we operated her, and now we are following her up. So we can provide information if she is asking for any information, but you cannot personally be involved in that. Take the opportunity to suggest to her that she may find it beneficial in the long run to consider going through the formal complaint process, because she was asking you regarding the complaint procedure. How can I take my complaint further? So here, just suggest the going through the formal complaint process as a first step. Okay, what is the formal complaint process in the NHS? Here it is. So it's simple. Okay. Now, I know that you have been knowing about the PALS system. Give the contact. Whenever the surrogate says, I want to complain, you just provide the contact details of the PALS system. Okay, do you know what happens after that step? This is what we're going to talk about. Because again, this question has been showing up lately in the exam, okay? So explain the formal complaint process in the NHS. Number one, explain the first step in the process would be to write a formal letter of complaint. The patient who wants to complain, he needs to write a formal letter of complaint. And that should be addressed to the practice manager at her GP surgery, all right? Containing the details of what had happened previously. So that's her formal complaint letter. It should be handed to the practice manager at her GP surgery. This is the first step. All right. So then there are systems in place to deal with the complaint internally. So what's going to happen is that there are going to be trials to solve the issue internally before escalating the issue to the court, etc. So if it was solved internally through communication and discussion, okay, that would be very nice, okay? But if that didn't happen and the patient wasn't happy and they want to take the complaint further, then comes the next step, okay? So as we are talking about a GP, the patient's GP here, so that's why the explanation is going to be about the GP, and then I will explain how it's taking place in the NHS. It's not very much different, although. So there are systems in place to deal with the complaint internally within the surgery first, and then at the level of the primary care trust or higher authorities if required. Number two, after the patient wrote the formal letter of complaint, okay, give her the contact details of the patient advisory liaison service. However, when the patient says that I want to complain, we give her the contact details anyway, and then she will write a formal letter of complaint and hand it to her practice manager of the GP surgery. Now, why do we give the contact details of the PALS? Because the PALS can give her more information about the NHS complaint procedure. Okay, now the patient she came in this follow-up 6 months post-surgery follow-up appointment. This is in the hospital. She's with you in the hospital now, and she's talking about complaining against her GP. So here we have, you should give her the contact details of the patients as Okay, so give her the contact details of the patient advisory liaison service. You can give her more information about the NHS complaint procedure. And they will probably have an office in the hospital. So she may wish to go there after this consultation with you to make an appointment with them, okay? Now, why do we give them the contact details of the PLS? The PLS role is they will try to solve the issue informally first, internally first, before any further escalation of the issue to the legal parties, okay? So the PLS will address immediate concerns of the patient. The PLS will arrange meetings with the staff members, okay? And they will advise the patient who made the complaint, okay, on access to other services as formal complaint procedures if they wish to take the issue further. So this is the role of the PLS, okay? Question, some examiners ask, what do you know about the PLS? The Patient Advice and Liaison Service. This is an independent service available in most primary care trusts and NHS hospital trusts. It's an independent body that can assist patients and relatives by, this is their role, this is what they do. They address immediate concerns of the patients, they arrange meeting with staff to solve the issue informally, first, internally, before any further escalation is made. If the patient is unhappy still and they want to take the issue further, they will give them advice on access to other services as the formal complaint procedures. And now I'll talk about the formal complaint procedure and how it's done. Okay, so number three, reassure the patient that her complaint will be taken very seriously by the relevant authorities, and she would expect to receive a formal response from them, usually within 28 working days. So this is the formal complaint process in the NHS. First of all, she says that she wants to complain. You give her the PLS contact details, and you know the role of the PLS and what they do. Okay. Then she needs to write a formal letter of complaint. If she says that I want to complain formally, please, doctor, advise me. What can I do? Or maybe that's the examiner's question. What do you know about the formal complaint process in the NHS? So these are the steps. The patient writes a formal complaint letter in order to try to solve the issue internally. The PLS will be contacted in order to assist the patient and try to solve the issue informally, internally first. If the patient is still insisting and unhappy and want to take the issue further, the matter further, they will give them advice on how to do and go through the formal complaint procedure. And her complaint will be taken seriously. Okay. Number 4, if she's still not satisfied with that and wishes to take legal action, tell her that she will need to consult with solicitor. Once again, the PLS team can give her better advice on that. So they will assist her even through that process and guide her. Okay. Now, these are the 4 steps, okay? So the NHS complaint procedure have an expect that the doctor will provide information to the patient about the process of submitting a complaint if they asked you, and explain where they can go for further advice. Okay, so the most common reason why patients complain is why patients go and complain is with poor communication. That's why doctors are being trained on how to communicate with angry patients and angry relatives and apologize for medical errors or malpractices and acknowledge the mistake and offer help and explain what system you have in place to prevent this from happening again, addressing their concerns, okay? Because good communication can solve many issues internally, okay? It can save us the legal headache, you know? So the most common reason why patients complain is to do with poor communication. So it's wise for the doctor to try and resolve the issue and concerns with the patient in a face-to-face meeting before any escalation is considered. Number 2, people who are upset, distressed, or angry need to be heard responsibly. There are skills how to deal with an angry patient or an angry relative, okay? These skills are very important and very useful. So you have to use them when you communicate to a patient, an angry patient. So this means carefully with minimal interruption, listen to what they say without burdening the patient with the excuses or opinions of the doctor, okay? In this way, the doctor will significantly reduce the likelihood of further escalating the annoyed person's magnified feelings and thoughts. And in most cases, it's advisable to contact the colleague whose judgment is under scrutiny here as her GP. I mean, you should not make any decisions about her GP because you're not in a situation or a position to do that, okay? Instead, you have to have a neutral attitude, okay? Don't blame the colleague and don't ignore the patient's concern. She asked for your advice to explain the complaint procedure, advise her about the complaint process in the NHS. She wants to complain, give her the contact details of the PLS. She wants you to be involved in the complaint personally. Tell her that you cannot do that. But if she needs any information about the diagnosis or the treatment which was provided to her, your consultant or the neurosurgeon can do that. Okay? So ideally, the colleague who did the mistake or the delay in diagnosis or messed up, let's say, okay, whose judgment is under scrutiny, and discuss the case before advising the patient that an oversight or error has occurred. We cannot say to the patient that, yeah, you're right, there was a medical error which happened, okay? Because, as we said, ideally the patient who is responsible or under question is the one who should be contacted, okay? And excuse me, I'll just mute the background. Just a second. Yeah, all right. Okay. So it's advisable to contact the colleague whose judgment is under scrutiny and discuss the case before advising the patient that an oversight or error has occurred. That's why we give the patient the contact details of the PLS, because they will arrange meetings with the staff member who the patient is complaining against in order to try to solve the issue internally before any escalation is done. So here you see this algorithm here describes the NHS feedback and complaint procedure in the UK. Okay, they call it as a two-tier system. NHS complaint procedure is a two-tier system. First of all, they will try for local resolution by the NHS Trust or Primary Care Trust. If the patient is unhappy with that, then Parliamentary and Health Service Ombudsman, the PHSO, can be involved, all right? This is an independent body. Let's take a closer look. Here, many concerns can be resolved through giving feedback directly to the provider, such as a hospital or the GP surgery, okay? Patient may also wish to provide feedback about what okay, so but here, as we are talking about a complaint, okay, so here they can first of all try that many concerns can be resolved through giving feedback directly or the complaint directly to the provider as the hospital, okay, or the GP surgery. If the issue is resolved, that's okay. All right, so no further action is needed. But if the issue is not resolved and they want to make a complaint, so first of all, they will give their feedback about what they, their opinion. If the issue is resolved by communication, face-to-face communication between the doctor and the patient, for example, and the issue was resolved, no further action is needed. But if the issue is not resolved and they say, I want to complain. Let's say, for example, there is a very famous scenario, the penicillin medication error scenario, where the patient was allergic to penicillin and she received a penicillin and drug, and she had a reaction. And it's a very well-known, famous scenario. And now you're sitting with the patient and you're explaining, or her daughter, and you're explaining what happened and you're apologizing for the mistake and so on. So here she's angry. She wants to give you her feedback. She heard that her mother received penicillin despite that she told you, and she told the triage nurse, for example, that her mother was allergic, and she found out that she was given penicillin anyways, and now she's angry and she wants to give you her feedback. And so try to solve the issue internally. Issue is not resolved, and she says, I want to complain. So here, if she wants to make a complaint, she can either go directly to the organization that provided the care, the NHS, or any relevant organization that bought the service, okay? So if the issue was resolved through communication and the PLS resolved the issue internally and so on, no further action is needed, okay? But if the issue was not resolved, even after giving the contact details of the PLS, and the PLS arranged meetings with the staff and they tried to solve the patient's concerns in order to solve the issue internally, it was not resolved. So here, the patient so here the patient can refer their complaint to the Parliamentary and Health Service Ombudsman for further investigation. Okay, so that's the complaint process. Okay, so although most complaints will be resolved at local level, this is when a complainant needs to be told that they have the right to a review by the PHSO if they are still not satisfied with the outcome of their complaint. So again, at the local level, the complaint may be delivered either verbally or in writing. The receipt of the complaint, this is for your information, okay? I don't think that this discussion will I'm sorry, doctors, I'm having internet interruptions. Yeah, there are connection issues here. I'm very sorry for that, okay? So the complaint manager within the trust will then go through the case in more detail, obtain statements from the staff members involved, and provide a clear and complete response to the complainant within a reasonable time, all right? Remember, services that patient can access to assist the complaint process are the PLS. All of you already know the PLS, and you give the contact details whenever they say that they want to complain. And now you know the role of the PLS and what they do, okay? And number two, independent complaint advocacy service. These are the two services the patient can access if they have a complaint. And they will get or receive assistance through the complaint process through these bodies, okay? If they are not satisfied, they have the right to review by the PHSO, which is the here, the Parliamentary and Health Service Ombudsman, okay, for further investigation. So in primary care, the process of managing a complaint may be slightly different at the local level. Again, if the patient hands his complaint to the GP surgery, there is going to be trials for local resolution, first attempted by the practice manager or the GP involved and the GP involved. If this doesn't lead to a satisfactory outcome, the complaint may then be escalated to the primary care trust complaint manager. And then the other regulatory bodies are the same, whether, like the NHS, whether the complaint is made at primary or secondary care level. Okay, so that was basically the complaint process and how it's done or how it's made in the NHS. Okay, that was the scenario, basically talking about that. Okay, so we still have history scenario. Okay, do you need a break, doctors, for a few minutes, or should we start straight away with the history? And I need someone who's interested to practice history. This is also a scenario which came frequently in the last diet. It came several times. So yeah, Dr.
Yes,
Ahmed.
Doctora.
Yeah, we have Dr. Ahmed Nasser.
Yes.
Yeah, you raised your hand. Are you interested to practice, or do you want to ask a question?
Yes, I'm interested in practicing.
All right. Yes.
Just
So do you need to break? Do you need to break, doctors, or should we just continue?
It's up to you, doctor.
All right. So we will continue then. All right. I don't have any problem with either. So just let me know. Okay. So we are continuing, and I'll just stop the share for a second because I don't want you to have a look at the slides, okay? It should be hidden so that you can reach the diagnosis through history. Okay. And Dr. Ahmed? Dr. Ahmed Nasser?
Sorry.
Okay, here is your scenario. Here is your scenario. And you have 4 minutes, okay? I'll give you 4 minutes to plan your answer and your approach to the station, and then we will start.
Okay.
Are you ready?
Yes, doctor. Okay.
Okay, you can start.
Okay. Hello, I am Dr. Ahmed Nassar, the treating physician in the medical office or in the general medical clinic for today. Nice to meet you. I suppose you are Mr. Lorna Smith, 31 years old. Is that correct?
Yeah, that's correct. Nice to meet you, doctor.
Nice to meet you, Mrs. Lorna. Mrs. Lorna, we are here to discuss your medical condition. Is this okay with you?
Yeah, it's okay.
Okay, can you tell me more about your medical condition, please, Mrs. Lorna?
Well, doctor, actually, I don't have these symptoms right now. They are all resolved completely, but I'm concerned that it may come back again. So that's why I'm here today to tell you what happened with me, okay? Everything started over the last 6 weeks. Actually, I had 2 episodes of what happened. Each episode took, there was 2 weeks between each episode. Doctor, I got a huge facial swelling. My face was so puffed and my lips were so swollen and my eyes were also swollen very much. And I also had some itchy lesions there in my hands, and it happened at first, and then after 2 weeks it happened again, and now I'm here because I'm afraid that it may happen for a third time. So what's my problem, doctor? I don't know. What is this?
Okay, I'm very sorry to hear this, and I hope I can solve your problem. But can I ask you a few questions first to get a better understanding of your medical condition?
Well, I don't know what I have. I have this swelling. My face gets puffed, as I told you.
I'm saying, can I ask you a few questions first to get a better understanding of your condition?
Yeah, sure.
Taking information, yes. Okay, you mentioned that it started first 6 weeks ago. Is that correct?
Yes.
And where exactly in your face was this swelling?
It was first of all, as I told you, my eyes, and also my lips, my mouth, and my tongue I was feeling numb also, and then I had a kind of a strange rash on my hands also.
Okay, and for how long did it last each time?
Well, both episodes, they develop rapidly over about 20 minutes, okay? And I don't remember actually for how long, but I went to my GP immediately, and he gave me some treatment, and the symptoms improved within 6 hours. But they were completely resolved after 72 hours.
Okay, I'm glad that it's resolved. But can you tell me, please, let's get back in time, please. Can you tell me if anything, you have taken any drug or type of food before this happens to you? Like any special type of food that may cause you allergy?
No.
Have you taken any type of drug, like new drug, or increase the dose of any drug?
No.
Okay. And when exactly this happened to you, in the morning or in the evening?
I don't remember actually.
Okay. And are you allergic to anything, Mrs. Lorna?
No, not as far as I know.
Okay. Do you take any medications?
No.
No medications at all. Have you traveled abroad recently?
No.
No travel abroad. Okay, no allergy. And you don't have a previous history of any form of allergy, like bronchial asthma or allergic rhinitis or anything like this, right? Is that correct?
No, I don't.
You don't have any of these. And you don't. Can I ask you some private question? Do you take any recreational drugs?
No.
No recreational drugs. Okay, and this happened 2 times before. Have you been bitten with any sort of parasite or anything of insect before this happening?
No.
You're sure it's never happened? Okay. Have you experienced any fever with this form of allergy?
No.
No fever. Any weight changes, like weight loss or weight gain?
No.
Can you describe me the rash that happened in your hand? How was the shape of the rash?
Well, it was very itchy. Okay, intensely itchy, and it was reddish. It was red in color. There were so discrete, well demarcated swellings on both my hands. And they were very intensely itchy. I mean, what is that, doctor?
Okay. Can I ask you, please, with whom do you live with?
I live with my family. I'm married and I'm a mother of two.
Have anyone experienced the same condition as what happened with you in the family?
No,
Not at all.
no.
Okay. And what's your job, please?
I'm a housewife.
You're a housewife.
Yeah.
Okay. And do you use any new type of detergent or so in cleaning the stuff at home?
No.
Nothing. You don't do the hand wash or so, the cleaning of the tools or so?
No. I mean, I use cleaning detergents, but I never had any allergy to any of these
Tried any
detergents.
sort of, okay.
No.
And you didn't use any new type of clothes or new types of gloves or so?
No.
No, at all. Okay. Somehow difficult. Have you experienced any bumps or lumps in your body?
No.
Any muscle weakness?
No.
Any skin changes before any skin changes rather than this rash in your hands 6 weeks ago?
No.
Like any rash or redness or any sort of this in your body?
No.
Have you experienced any joint pains?
No.
Any problems with your water work?
No.
Any problems with your bowel habits?
No.
No problem with your bowel habits. Any weight changes, like weight loss or weight gain?
No.
Change in appetite?
No.
And you mentioned no fever at all, right?
No.
Just two episodes of itchy facial rash associated with the hand rash.
Yeah.
6 weeks, and another one after 2 weeks.
Yeah, and my tongue was feeling numb. But when I went to the doctor, he gave me those treatments, those drugs, and I was feeling better. Excuse me, I will mute the background. Okay, continue, Dr.
I'm trying to find a solution. Itchy facial rash. It's difficult for me. Do you have any family history of similar condition?
No.
Any past history I should be aware of?
No.
Any atopy as a child? Any form of atopy as a child?
No. No.
Everything is no. Okay. Facial swelling and tongue swelling. Okay. What's your concern, Mrs. Lorna?
I'm concerned about these swellings I'm having, and I wish to know what's causing it and how can it be prevented? How can I prevent another episode from happening to me? Because it seems like it's coming back every now and then.
Yes, okay. I totally understand your concerns and worries, and I'll try to solve this problem. First of all, we need to perform further tests and investigations to confirm the diagnosis of your condition. But most probably have a condition called hereditary angioedema. This is what I can say. It's a problem that can cause you edema, facial edema, and swelling in your tongue, and so. And it's relieved with this medication like prednisolone and chlorpheniramine. But
Okay.
as I told you, we need to perform further investigations and tests to exclude or confirm this condition, and we need to do some blood tests to check for the presence or absence of the enzyme that can cause this condition. Also, we need to perform some routine investigations, and we can inform you with the results as soon as these investigations are released.
Okay. And how can you prevent this from happening again? What should I do?
This diagnosis was confirmed. We need to give you a replacement of the enzyme if it's confirmed the deficiency of this enzyme. which is C1 esterase enzyme. I can give you a replacement with this enzyme, and you can you will need something called epinephrine pen with you to take it if you suspect if this condition happened again. It's life saving. It clears the airway if anything. If the edema in your edema of your tongue and mouth causes obstruction of your air passages. So you need to take an epinephrine pen, and I can give you this prescription of these medications to take if this happened again.
Okay.
Do you have any further questions?
No.
Okay, and I think I can make a genetic testing, but I'm not sure of this genetic testing, so I won't mention it.
Okay. Did you finish?
I will ask about social history, married, of course, smoking, alcohol, recreational drugs.
No,
Job.
not taking any.
Job, you told me housewife. Travel, you told me mention no travel abroad. Past history, no. Family history, negative. Drug history is negative. So I don't have anything other to add. Hello? Hello?
Yes.
Dr. Nad, are you
So
here?
no, there is no smoking, no alcohol consumption, no recreational drugs.
Okay, I will ask
So
about the
did you finish?
menstrual history and the female menstrual
What
history,
else?
pregnancy,
Yeah, sure. Okay.
driving, and do you drive? Because this condition may cause problems in driving.
What else?
Job, of course, travel, past history, family, drugs, and I think nothing else. Nothing else. I don't have any other thing to add.
Okay. All right. Thank you very much.
Thank you.
So, what's your diagnosis or your differential diagnosis? What do you think she has?
I think she has something called hereditary angioedema. She's a hereditary condition with C1 esterase deficiency that causes swelling in her tongue and lips, and it occurs in episodes.
Yeah, but she said that she has urticaria and it was intensively itching wheals in her hands, and she said that her tongue was feeling numb. So there is possibly that. Did you ask if she had any anaphylaxis?
Pets. I didn't ask about pets also. Maybe she has having scabies. I'm not sure.
Okay, usually hereditary angioedema, where there is C1 inhibitor deficiency, okay, this kind of angioedema is not associated with urticaria, pruritus, and anaphylaxis. These are not present in this type of angioedema. Yes, but she said, she described that she had those wheals in her hand and they were itching, and her tongue was numb, but you didn't ask further about the wheeze. Did she have any wheeze or any laryngedema? How she said that my doctor, he gave me treatments and it resolved. So you have to assess that episode more in detail. And also when you explain the diagnosis for her and explain the situation, always, whenever a patient has a situation or a disease, either in communication station 4 or in station 2 or in station 5, and there is something you need to warn the patient about, please don't forget that. This lady, she needs to be educated about any symptoms of anaphylaxis. She may get the episode again, right? And if that happened, educate her about those symptoms. If you feel any tongue numbness again, or any difficulty breathing, or any whistling in your chest, or any difficulty, let's say, for example, yeah, breathing, okay, or you feel that you feel like you're dizzy or feeling faint or something, you have to come immediately to the emergency department, okay? And also you have to write to her GP about that as well. All right, so it's very important to educate this patient about that. Now let's take a look. I will give you my feedback about your history taking, okay? I think that you assessed the risk factors for her for this angioedema very well, okay? You asked about all the possible precipitating factors, but she didn't have any, and she doesn't have to have any, okay? What you're expected to do in the exam is to go through those precipitating factors, but it doesn't have to be related to anyone known, anyone of them, because it's possible that there is no obvious cause for the urticaria and angioedema, and it's not uncommon for the cause to remain unknown. Therefore, routine, detailed investigations are not justified in those patients, as you took detailed history. After all, the management is about educating them about any alarming signs and symptoms of anaphylaxis, if they develop, and when they need to go to the hospital urgently. And then the management is basically to avoid any precipitants or precipitating factors. You have to advise her to avoid drugs like opioids, like aspirin, avoidance of anything that may degranulate the mast cells, okay? And then you will keep her on non-sedating antihistamines, which should prevent the recurrences, okay? Because obviously there is no underlying precipitant from the history. So this is the approach in such scenarios. This is a scenario, this is an atypical scenario, you know. I'll show you why. Please take a look at the screen, doctors. This case highlights the importance of taking a good history in the absence of the current symptoms. She came to you and she is describing past symptoms. She doesn't have them. It's not like a patient who comes to you with a chest pain or a headache or tummy pain or diarrhea or whatever, okay? This patient is describing previous episodes, all right? So there is a particular emphasis on the precipitating factors because we are recalling what happened, okay? So this is the category of this scenario. The approach here is that, here is the patient, okay? Can you see the pictures? She experienced angioedema of her face, okay? Her eyes were involved, her face, her lips, okay? And she said that her tongue was feeling numb. And also she described articarial wheals, intensely itching and red in appearance and well demarcated on her hands. And she doesn't know the reason of that. And what's against hereditary angioedema is the urticaria, which was associated with this situation, okay? So now here, the approach should be, what you need to do in the scenario, number one is to assess a history and a description of the urticaria. And well circumscribed erythematous wheal, the site of them itchy or not, anywhere else they appeared, okay? And then take accurate history of the angioedema itself. Where did it happen? Localized edema involving subcutaneous or submucosal tissues, okay? And you did that. You assessed the complaints or the event, or let's say the problem itself, the urticaria and the angioedema. Now she doesn't have any, but you have to take history of these episodes when they happened. What did it look like, the site, aggravating, relieving factors, was it itchy or not, appearance, etc. Okay? And how severe was it? Also, it's important to search for the allergic causes, and you did that very nice, okay? Indeed, I mean, you went through everything. I liked the way you did it, okay? Although in this case, there's no obvious precipitant. You would never find a precipitant from the history, but you have to ask about everything, okay? Number 4, you have to explain the management here. So if the urticaria was due to a physical stimulus, as cold or deep pressure or heat, stress, I got a message in the inbox saying stress is one of the precipitants. Yeah, it is, okay? Then avoiding such a known cause is the primary treatment. and provide prophylactic treatment and educate about what to do if alarming symptoms develop. This is the main plan of management in this situation. Okay, now this is the scenario we're talking about here, but maybe in the exam you will find that the case is hereditary angioedema and there will be no urticaria in the hands, and the patient will just describe the angioedema and possibly there is a family history. So the scenario may change, okay? But here we're talking about the different possibilities. This patient, she had both, okay? So that's against hereditary angioedema. So the candidate should be able to, again, you have to assess the lesions, okay? How severe was it? Was there any associating anaphylaxis or not, okay? And search for the allergen and set a management plan, because that was her concern. She was afraid that it may happen again, okay? So the candidate should be able to assess fully the patient's symptoms as she describes them. Now that she's asymptomatic, today she came to you asymptomatic, fully assess the possibility of a precipitating allergen, because she may have the attack back, but there wasn't no allergen known at least, okay? Show empathy, reassure the family that the symptoms, because she may say that she may have her family with her, her husband or a family member attending the meeting with her. Maybe that's okay. Reassure the family about symptoms, that they are rarely severe and dangerous, but explain what to do if laryngeal swelling should occur, the symptom, if she developed any stridor, any whistling of her chest or her throat, okay? You must educate them about warning signs and symptoms and what to do if they develop. They need to come to the hospital urgently, okay? So, explain that there is no obvious cause for the urticaria for now, because she will say, what is the problem, doctor? You have to be open about it, okay? You have to explain that there is no obvious cause for the urticaria and angioedema, which happen together here. And it's unknown for the cause to remain unknown. So, uncommon. It's uncommon for the cause to remain unknown. So routine detailed investigations are not justified here. You should not over-investigate the patient in such a case, okay? Explain that most idiopathic cases may last for a few months so that the patient have an expectation about the chronicity of the situation and the possibility of recurrence, okay? So it may last for a few months before resolving altogether. It may resolve altogether later. Although occasionally some people go on to have a chronic urticaria with recurrent episodes. That's why our management plan includes, first of all, avoidance of some precipitating drugs like aspirin, like opiates, and give her regular non-sedating oral antihistamines for prevention as cetirizine 10 milligrams or loratadine 10 milligrams, okay? And oral non-sedating oral antihistamines, if there is a driving issues, they are non-sedating anyways, okay? History of the past episode, okay? Again, remember, you have to explore an exact description of the wheals on the hands and the facial edema and the parts that are affected.
Excuse me, doctor, I have a question, please.
Okay, it lasted for 72 hours. And the response of the symptoms to antihistamines and prednisolone, she said that the symptoms, they disappeared completely after 72 hours on treatment. Okay, this treatment was actually, if you ask me, I would say steroids and antihistamines. Okay, any associated symptoms, especially the suggestive of laryngeal edema, did she experience any? No stridor, no dyspnea. Ask her, please. Any gastrointestinal or systemic disorders, you asked about fever, arthralgia, and myalgia. There was no, any of them, neither of them developed. Only tongue numbness, okay? And then I go on by assessing any obvious precipitating causes like trauma, local pressure, emotional stress, inhalatory allergens like pollen, animal dander, mold, insect bites, extreme cold or heat, solar rays, allergic contact substances as metallic jewelry, dog or cat hair, and saliva. So these are possible. If she has any pets at home, it should be asked about in the social history. But however, this patient doesn't have any precipitants anyway, okay? If she has any previous food allergies as fruits, strawberries, food coloring agents, shellfish allergy, chocolate, peanuts, these are common foods associated with allergy. Any past history of atopy or eczema, allergic rhinitis, asthma, recent viral illnesses, SLE, thyrotoxicosis, lymphoma, these may present with urticaria, but she doesn't have any. Any family history of angioedema? There is no family history of angioedema. Then take a full drug history, concentrating specifically on non-steroidal anti-inflammatory drugs, aspirin, angiotensin-converting enzyme inhibitors, opiates, penicillin. These may cause this presentation in the patient. All right. Then obtain alcohol and smoking history, social history. Okay, asking specifically about pets. Okay, occupational history, concerns she has, and you already covered most of these. Okay, so this is the how to assess any obvious precipitating causes in such a scenario. I'll leave this slide for a few seconds so that you can, if you want to take some notes before we go to the second slide, because there is a list of differential diagnosis that you may be asked about what other causes may lead to a similar presentation. So that could be the examiner's questions.
Dr. Anada, please.
Yeah.
I have a question.
Yeah, sure.
It can also be a trigger for any allergy or something like that. We should ask and ask the patient to change the OCB.
Well, you can ask her if she's taking any oral contraceptive pills, okay? But usually, it's, I mean, any drug can cause allergy, okay? Whatever it is, any medication. Yeah. But the OCP, you mean as a well-known triggering factor like the nonsteroidal and aspirin, it's not mentioned among the list, okay? It's not mentioned among the drugs that you should ask about in the full drug history, especially the things you need to concentrate on are the nonsteroidals, the ACE inhibitors, aspirin, opiates, and penicillins, basically, okay? But however, any drug can cause allergy.
Yes, okay, thank you.
Most welcome. So the management, again, primarily include reassurance in this situation, avoidance of aspirin and opiates, which can degranulate the mast cells, the regular use of oral non-sedating antihistamines, which should prevent recurrences. She was asking specifically, how can I prevent a further episode from happening? It's important to stress this to the patient. And in the GP letter, severe angioedema with laryngeal swelling, if stridor happen, will need urgent admission to casualty for emergency treatment and observation. Please, this is a risk stratification point, which is very important to stress on in such scenario.
Dr. Ananda, please, how we can ask about stridor without jargon?
If you experience any difficulty in breathing, or if you started to breathe with difficulty and making some strange sounds like wheezing sounds of your chest or your throat, for example, okay? Describe.
Okay.
There is a question. There are questions commonly or frequently appearing about how to avoid medical jargon, and some doctors, they memorize some lists, okay, where there are some collections of layman words or terms and how to use them to substitute medical jargon. However, if you didn't find the word specifically, okay, just describe what it is. Like, let's say, for example, psychiatrist. Okay, the word psychiatrist. Psychiatrist is a medical jargon, all right? But instead of say in the UK, they don't say mood doctor. Many candidates, they use the word mood doctor, okay? But you don't have to say mood doctor, because mood doctor could be the psychologist rather than the psychiatrist. And there is a difference between a psychologist and a psychiatrist. So simply say psychiatrist is my colleague, is a doctor who see people who have, or patients who have problems similar like yours. Okay, problems with their mood, with their sleeping pattern, or change in their food and mood and so on, okay? Explain. I mean, don't be confused if you didn't find the layman word of the jargon you have. Just explain what that is. Explain it in simple terms, what the medical term is, in English, of course, okay? If you stuck and you didn't find the specific word. All right, let's take a look at the pathophysiology, okay, of angioedema and urticaria, just to make things clear. There are two basic pathogenic mechanisms for angioedema. The first mechanism is mast cell mediated angioedema. This is usually due to allergens, okay? That enhances the mast cell release, like allergy to food products, insect stings, drug allergy as antibiotics or non-steroidal anti-inflammatory drugs, and it's associated with urticaria and pruritus in most cases. In severe episodes, it can lead to bronchospasm or anaphylaxis. So that's the mast cell mediated angioedema, usually due to underlying allergens, can present with urticaria and pruritus in most cases. The other type is the bradykinin mediated, where there is a buildup of bradykinin, which causes the vasodilatation and increased vascular permeability in angioedema. And this can be due to drugs like ACE inhibitors or defect in the complement system, as in the hereditary angioedema due to C1 inhibitor deficiency. But in this type, urticaria, pruritus, and anaphylaxis are not present in this type of angioedema, but these are present in the mast cell mediated angioedema. Okay, that's just to make it clear the difference between the two of them, just in case if you were asked this question by the examiners, okay? The examiner may ask for other possibilities. What other possibilities are there? Other possibilities, differential diagnosis of this angioedema and urticaria, okay? So the differential diagnosis could be contact sensitivity, where this is a vesicular eruption that progressed to chronic thickening of the skin with continued allergenic exposure. And this is the contact sensitivity, how it looked like, okay? Contact sensitivity, contact dermatitis, okay? It can happen in the face, it can happen in the limbs, okay? So it's a differential diagnosis. It's a vesicular eruption that progressed to chronic thickening of the skin with continued allergenic exposure. Another differential diagnosis could be atopic dermatitis. It's a condition that may present as erythema, edema, papules, vesiculation, and oozing, okay? This is atopic dermatitis. Okay, this is another differential diagnosis to angioedema and urticaria. Can happen in the face, on the limbs, anywhere, okay? So erythema, edema, papules, vesiculation, and oozing. Another differential is cutaneous mastocytosis. This is a reddish-brown macules, papules, and urticaria with itching, pruritus upon trauma. That's why we asked about history of trauma in the history. So this is cutaneous mastocytosis, reddish, brown, itchy lesions, okay? It may happen or precipitate by trauma as well. So reddish, brown macules, papules, and urticaria with pruritus upon trauma. The fourth differential is systemic mastocytosis, which is episodic systemic flushing with or without urticaria, but no angioedema. Usually it's not associated with angioedema here, okay? Could be episodic, systemic flushing, with or without urticaria, but no angioedema. So here, this is systemic mastocytosis. Okay, no angioedema in this type. This is the shape of the lesion. These are the differential diagnoses. Okay, again, contact sensitivity or contact dermatitis, okay? Some ladies develop contact sensitivity in the face upon so it may look like somehow may look like, you know, facial lesion, facial swelling. Yeah. Okay, atopic dermatitis, cutaneous mastocytosis, systemic mastocytosis. These are the differentials, okay? And by that, we reach the end of our session tonight, okay? These were three, yes? Yeah.
I have a
Is this
question.
Dr. Nermi?
Yes.
Yeah.
Yes.
Okay.
How are you?
Dr. Nermi? Nice to hear from you.
Thank you very much. It is
Okay.
very beneficial session. Thank you. I have a question. When we showed the EpiPen and the medic alert bracelet?
Well, whenever a patient has an allergy, okay, you can advise them to carry a medical alert bracelet. There are some indications for a medical alert bracelets. One of them is allergy, either to drug or food, or whenever a patient may develop an anaphylactic reaction, then they should be advised on carrying a medical alert bracelet. Okay, this is a good point. You can add that too among the management plan, your management plan, okay? Now the EpiPen, well, it depends on whether if, I wouldn't say that in this scenario. I'm not sure exactly whether if you should advise the patient to carry an EpiPen with them always, because you educate them about any alarming signs and symptoms, okay? And when to go urgently to the emergency department or the hospital. You keep them on the prophylactic drugs. They carry a bracelet, okay, medical bracelet, but the EpiPen, maybe it is. How exactly you should approach that, I will check it and I will share it in the groups, okay? How exactly you should do it and advise the patient about that. If he should, as he has an allergy and anaphylaxis, they should carry an epinephrine pen, of course. But how exactly you should say it, I'll check it, okay? And I will share it in the group. Let's take a look at the questions here. For why allergy anaphylaxis here, what was the cause? Doctora Irene, okay, she is asking for what is the cause of allergy anaphylaxis here, and what was the cause? The cause here is not known, okay? It is a case of an unknown cause of this angioedema and urticaria, and it's a idiopathic case, okay? And that's why we said that you have to explain to the patient that most idiopathic cases may last for a few months before resolving altogether. And some patients may go on and have chronic urticaria with recurrent episodes. And that's why we educate them about alarming signs and symptoms, and we keep them on prophylactic treatment, okay? No obvious cause, but all
repeat the
symptoms
differential
for
or the
allergy.
can you see
You need
the differential diagnosis, please?
Yeah, just a second. Differential diagnosis was here: contact sensitivity, atopic dermatitis, cutaneous mastocytosis, and systemic mastocytosis. Okay, and of course, the patient has angioedema, which could be either mast cell mediated, and in this situation, there is a precipitating allergen known usually, but sometimes if it's not known, it could be considered idiopathic. Okay, over-investigating the patient in this situation is not justified. Just reassure them, educate them about alarming signs and symptoms, and keep them on prophylactic treatment as non-sedating antihistamines, okay? And educate them about which drugs they need to avoid and which precipitants they need to avoid, okay? The mast cell-mediated angioedema is associated with urticaria and anaphylactic episodes. But the bradykinin-mediated angioedema, which is the other type of angioedema, okay, can be precipitated by ACE inhibitors, or it could be hereditary angioedema due to C1 inhibitor deficiency. In this type of angioedema, urticaria, pruritus, and anaphylaxis are not present. Okay, this is the difference between them. Both are angioedema, but mast cell mediated has precipitating allergens, and it's associated with bronchospasm and anaphylaxis. Also can present with urticaria and pruritus in most cases. The bradykinin mediated is not. Okay, just angioedema, which could be the hereditary type or due to ACE inhibitor. Okay. Let's see the other questions in the chat box. Okay, what is the 4Ds of negligence? Okay. All right, what are the difference between, I'll go to the 4Ds of negligence, okay? Just a second, Dr. Abu Ubaida. I have a question from Dr. Muhammad. He's saying, what are the differences between anaphylaxis and urticaria? Urticaria is the skin lesion here. This is here. The urticaria is a description of this wheals, the skin lesion here. Itchy, reddish, wheals, raised, okay, palpable, well demarcated. This is urticaria. This is the lesion itself. Anaphylaxis is when there is a systemic reaction with associated laryngeal edema, stridor, bronchospasm, wheeze, okay? If this is anaphylaxis, and then if hypotension develops as well, this can lead to anaphylactic shock. The patient may develop a shock. This is the severest form of the reaction, okay? But urticaria can happen without anaphylaxis. It doesn't have to lead to anaphylaxis, okay? The 4 days of negligence. A second, I'll share the screen of negligence with you, just to make it clearer, okay? Here is the 4 days of negligence. Can you see the screen, doctors? Here, negligence, is the screen visible to you, doctors? Negligence is a failure to exercise the care that a reasonably responsible or prudent person would exercise in like circumstances. In tort law, negligence applies to harm caused by carelessness. It's not an intentional harm. And to say that there is negligence must be directly responsible for the injury for a claim to be valid. And there are 4 legal elements that must be proven, which are the 4 Ds of negligence. And these are the claimants who want to complain against the doctor, and they are claiming that the doctor was negligent. They need to prove that the doctor had a duty of care when the mistake or malpractice happened, because it's had to be proven that there was a directly responsible for the injury for a claim to be valid. So the claimants have the burden to prove, okay, the 4 days of that the patient was in duty when the harm happened, and they must prove that there must be proof that there was a dereliction or that the negligence or there was a deviation from the appropriate standard of care. The appropriate standard of care is the protocol that the doctor should follow, okay? But if there was negligence and the doctor didn't follow the appropriate standard of care, he messed up, let's say he messed up, okay? Then that could be in favor for negligence. Also, there must be a proof that there was damage happened directly because of this malpractice and that there was a direct cause. The malpractice was directly causing the damage. These are the 4 Ds of negligence, okay? So, and basically there is a breach in the duty of care, all right? So this is simply to simplify the 4 Ds of negligence. Okay, most welcome, doctors. So this is the end of our session tonight. I hope you gained benefit from it. And thank you very much for attending. I wish you best of luck with your preparation.
Thanks a lot, Dr. Nada. Thanks a lot. It was very helpful.
Most welcome. Good luck.
Thank you.
Thank you very much. Okay, good night.
Good night.